Welcome to a very special episode of Healthcare Triage. We're going to dedicate at least this show, if not a few shows, to answering your questions about coronavirus. Tiffany is going to be asking our questions. She's sitting right over there, but not near me because we are actually acknowledging social distancing at this point. So she's got to be what? 12 feet, 15 feet away from me?
I think so.
We think that's a safe distance. So she's answering your questions. She's asking your questions, I should say. I'm answering your questions. Here we go.
Okay, so let's start with one of the most asked questions. What is the deal with NSAIDs? Should we avoid things like ibuprofen for now just to be safe?
So a lot of the concern about NSAIDs and ibuprofen has to do with some studies that looked only at viruses in the respiratory tract in general. None specifically with COVID. And some of those studies did show perhaps some associations that there might be some, getting a little bit worse or having some side effects if you had a respiratory virus and took ibuprofen. The best study I've seen, though, was a randomized controlled trial that gave people basically acetaminophen or ibuprofen or something like, an NSAID or nothing or some combination. And it found incredibly minimal differences, tiny, really tiny. And so I don't even know how much of this is there. This is old news. I mean, these studies are like a couple years old. It's not new. It is not COVID specific. And so everyone's concern about this just seems a little more than we need right now.
Okay, so what's being said on Twitter is that ICU physicians are saying that they've noticed a trend that people are worse off when they have been on NSAIDs.
So again, I don't know that these are actually informal studies and that we actually know you're going to hear anecdotal reports, but of course it's the anecdotal reports that are going to make the most noise. I have not yet seen any conclusive data to push us in that direction.
So the rest of the questions I've just tried to group. So this first group is going to be questions about social distancing and quarantine. So this first one, can you do things outside in suburban areas like walk your dog, basketball with your family, as long as you stay away from other people? And then what about playing on an outdoor golf course if there aren't a lot of people and you're away from others?
First of all, going outside, great. There's no reason to stay in the house. This is not like floating around in the air. But you want to follow the same rules with other people that you would follow in the house. Like walking with a neighborhood friend who's staying more than 6 feet away is fine. Like, don't get in the zone where they could cough and sneeze on you, then you should be fine. Playing basketball with the same people, like your family that you are otherwise in the house with, otherwise likely fine. Now, playing basketball with people that are not part of your social isolation group is not okay, really, because then that's just like hanging out with them. That's what we're trying to avoid. So being outside, if you're following the social distancing rules, is great. Being outside and close with people you are otherwise close to is great, but don't be outside with people you otherwise wouldn't be close to, because that's just as dangerous as being inside with them.
So I think that also answers the question. People wanted to know if kids could play together outside. So if they are your kids from the same house, yes. With neighbors, probably not.
It's easy to say nobody should ever see anybody. That's very difficult to hold down. So there's a couple ways you could theoretically go about doing this. One is if you have a couple families and you guys commit that these are the families that are only seeing each other, well, you've socially isolated yourself in just a slightly larger group. And if they truly commit to that, that's pretty much okay. Secondly, if you can agree to the same rules that I just said, it's fine. So we've told our youngest daughter, she can have one friend that she's designated over, but they have to, play by the same rules. More than 6 feet away, washing of hands, no sharing of anything. They can play together like a video game or something, but no making TikTok videos and fooling around. You got to respect those distances. If kids can do that on play dates and they're old enough, great. If you're talking about small kids, then again, if you set up with one or two families and say our kids are just going to socialize with each other and nobody else, and the families are not doing anything else, and you keep the group contained, then that's probably okay.
So I feel like that also addresses this question on should you refrain from having people over to your house?
Same rules I'd say would apply. If you can identify one, if we have sort of two families that we would consider perhaps, let's say two families that are best friends, so it's just three families, and if we say we're only doing our three families and nobody else, probably okay. In the same way I also said, I have a neighbor who lives across the street, he's a friend of mine. I imagine, if he came over and wanted to sit and chat and sat over there and I sat over here and we, followed the same rules and good hand washing, there's really minimal risk there. So you have to be smart about it, but you want to keep it to a minimum. I mean, you really do. The part of this is trying to keep social distance. And of course, if we go to serious quarantine and lockdown, you should probably stop even that, but we're not there quite yet.
Okay, and still keep all of this to groups, less than 10?
The president and the CDC said no group should be getting together larger than 10. I think that that's still too large. I mean, it's just, I would say, if you're getting together in a group of 10 people, unless you're all committing to sit 6 feet apart, it's a pretty large room. And so I don't know how we're actually pulling that off. Now, with our family, we're eating around the kitchen table, but that's because we're agreeing that's our social circle. And if you live in a family of 10, fine, keep the 10 people in the house. Nobody's saying break up a household. But you probably shouldn't be inviting a random 10 people over to your house at any time. That's not serving the purposes. It's very unlikely you're following the rules and keeping at least 6 feet apart from anybody else.
How do you practice appropriate social distancing in places like grocery stores and pharmacies that you sometimes really need to go to?
So clearly, of course, all the usual rules apply. Hand washing, hand washing, hand washing. Don't touch your face, cough in your elbow. Don't go if you're sick. Stay away from sick people. It's also better to go on off hours when fewer people are going to be there. It's better to avoid it when there's huge lines. As much as possible, keep your distance from other people. We could stand in line like 6 feet apart, making sure we're not sneezing or coughing on each other. Certainly the second you're done, wash your hands, again and again and again. When you unload the groceries, wash your hands. Just constantly get used to making sure you are clean and you've taken whatever might have gotten on your hands off. Certainly before you touch your face, certainly before you eat.
Is it okay to volunteer at places like food banks if you have no symptoms and use a mask?
This is where I would talk to the food bank and find out their policy. But again, they're going to want to restrict it to as few people as possible. The whole goal is we don't want lots and lots of people coming into contact with each other. So if they said we have a core of volunteers and these people are agreeing only to go up and back to the food bank and not do anything else, that would be ideal.
Should we cancel all non-critical doctor appointments in March, maybe in April? This person said, it feels like I should, but I don't want to leave issues unresolved for potentially months.
I'm laughing at this question because I get asked this question about should I cancel X by friends, family, and acquaintances all the time. And every single time my response is, it's going to get canceled anyway. I think it's very unlikely that a lot of these optional appointments over the next few weeks certainly are going to stay in place, be it a dental visit, a non-emergent doctor visit, a nail visit, a haircut. We're heading towards probably much more strict isolation, in which case they're going to get canceled. But the truth of the matter is, yeah, we probably should cancel them because they're just exposing us in ways that we probably don't need to.
Next question. Should student healthcare workers coming back from spring break be allowed to continue work on clinical rotations? Many are, even after having traveled.
I mean, our medical school just shut down all third-year rotations for medical school. And we're waiting to hear what they're doing on fourth-year rotations. I think that's going to stop no matter what. Because, again, I think we're headed towards, really only essential personnel should be exposed. And so I think, this is one of those theoretical questions that people are asking now that I think in a week will be moot.
How can families of healthcare workers support their family working in healthcare while still helping contain the virus? So how do they keep their kids, neighbors, et cetera, safe when someone in the home is a doctor, nurse, paramedic getting lots of exposure?
I've seen extremes on Twitter where doctors who know they're being exposed are moving into the garage to protect their family, which is just, I can't believe this is where we are. But I think we're living in a world where, look, as much as you can in a house, practice good hygiene, wash your hands, stay away from people, don't share stuff. My kids are all in high school. My oldest is in his room most of the time. So it's not as hard for us to do social isolation. If you have small children, it's much more difficult, almost impossible. Let's own it. It's almost impossible. But doctors who are seriously being exposed need to take as much care as possible to keep their families safe, but it's going to be very hard.
Should we bring parents home from care facilities, assuming no one in the home is sick? And then related to that, should I get my elderly parents to my house from another state before things get worse?
If you're committing to true isolation, like you're not going to leave your house, and you can drive and get your parents so that, they're not going to an airport, I guess it's theoretically possible that you could safely get them to you and then all commit to not leaving the house. But you would almost have to have the same rules that we're advising the elderly at that point. It would be dangerous for you to go to the supermarket and then come home and be near your elderly parents. You'd almost have to go shut down. So that's very hard to do. If they're in a nursing home or long-term care facility, I'd talk to the nursing home. I don't know what's safer, to be honest, whether to bring them home or not. Sometimes it's impossible. You just can't provide the care that they need, which is why they were in a facility to begin with. And of course, once they're exposed, I'm not sure how much good it does to bring them out. So These are the kinds of incredibly hard, no good answer questions that people are going to ask that are worth discussing, but I would do that your doctor, or your parents' doctor, and the healthcare facility where they are.
Is it safer to have your food delivered or to order food for pickup?
Great question. So I suppose it depends on how the pickup goes. So here's the thing: there's really not much evidence for transferring food as long as people are taking usual precautions. And of course, if you get delivery, they could put the package down, walk away. You could open the door, never be exposed to a human being. Take your food, unpack it, wash your hands. You're good to go. No exposure. That's possible with pickup. But it's also possible you walk in to pick up and there's 6 other people waiting to pick up at the exact same moment. And those are the kinds of exposures we're trying to avoid.
Okay. And I feel like it might be important to mention here that we should tip the people.
Oh, well, again, you're only asking me a safety issue. We should be as generous to everyone as humanly possible right now. We have canceled the people that help us clean the house. We are still paying them. And I say that not to brag and not to, but it's like as much as you can, help all the people that you can.
Yes.
Because they are utterly dependent on a lot of the income that is coming, and to completely cut it off will leave the most vulnerable of us at risk. So, yeah, tip as generously as you can. Like, I'm all for ordering food. I think, helping restaurants, helping the delivery, as much as we can, let's keep the economy going as long as it's safe. And food delivery is one of the few areas where it's like, we've got to keep that kind of stuff going. But of course, as much as you can, be as generous as possible. That should go without question.
Yeah. Okay, next group of questions is about testing. First one, why so many different tests? For example, why didn't the CDC just use the WHO test?
So, I've seen a lot in the media recently where there's questions now about whether the WHO test was really refused or really was being reserved for countries that were more in need. But the bottom line is we should have been developing tests, allowing universities to do so, getting companies. We are way behind the game when it comes to testing. Why are there so many? Because everybody's trying to develop them as rapidly as possible, and there's no one test that everybody knows to use. Usually it's like you're trying to do some kind of PCR and look for something that matches the virus itself. So you're going to see a lot of tests, but hopefully they're ramping up now, but we keep hearing that news and we're not seeing it yet. So we really need that as soon as possible.
Do we know, or should we be worried about rates of false negatives on tests? So having people testing negative that actually have it and then go spread it?
I think PCR in general has a pretty low false negative rate just because of the nature of the test. Of course, we just don't have the sensitivity specificity. We just don't have that because we don't have the tests. And of course, to get those kind of test characteristics, you'd have to run the test in a controlled environment on people you knew had the disease and you knew did not have the disease. And of course, we have no gold standard because we have no test. So all of these things are great questions. We are just not going to know. But at least what we've seen in the field and knowing PCR in general, the concerns of false negatives are low on our number of concerns right at this moment.
And tests are only going to show if you currently have it, right? Not if you had it and have since recovered without knowing.
Well, when we say have it, we got to be very specific because, of course, there's infected and there's sick. And those are two separate things. Lots of people can be infected and not show symptoms. They still have it. People who are sick have it. People who have been sick are now feel better but are still shedding virus have it. The point is the test will be positive until you stop shedding virus. I just saw a piece in Pediatrics recently that said really little kids can actually continue to shed virus, fecal oral route, for some time, which of course is a nightmare scenario for daycares, where if they're changing diapers and moving between kids, the game is up. So it's until you're not shedding virus anymore, tests will be positive.
So how then can we track people who did get it, got better, all without knowing, never sought out treatment? Because isn't that important to know for the final numbers?
So at some point we could do that with probably some kind of antibody titer test, but that is, again, low on the list of priorities at the moment. We need to know right now just a test of do you have it? And that's priority number one. At some point in the future, it'd be great to have those kinds of tests and know that data as well.
Someone asked, some places are not testing asymptomatic patients who have maybe other risk factors, like they've come in contact with someone, et cetera, because test supplies are low. Isn't that dangerous?
It's dangerous in terms of infectivity, but since we're giving people the advice, assume you have it and go home, that's the treatment. Remember, there's no therapy for this. And especially if you're mild enough not to require hospitalization, the therapy is go home and wait it out. So whether you are sick with another virus or whether you are sick with this, that's the advice we have. So the danger is just infectivity, not a danger to that patient. What we're more concerned about at the moment is how do we isolate people and keep them apart, and what do we do, and what kind of course can we expect in the hospital, which is why you're seeing, I think, the testing when there's in such limited numbers directed at really sick people. Now, all 58 members of the Utah Jazz got tested. They were not at risk. I don't know how that actually happened, but clearly we're not applying these kinds of rules and priorities across the board, and we should be. But we'd like to get to a point where everyone who has symptoms or is concerned can get tested. We're nowhere near there yet.
If I have symptoms, what should I do? Go straight to an ER?
No, my God, no. Call your healthcare provider, talk to them. They're probably going to say, if you are not seriously affected, you should stay at home because going out will put you at risk of infecting other people. There's nothing we're going to do at the moment. And since we're not even testing those people, there's really nothing to do. If you're sick enough to require evaluation by a physician, hopefully they'll direct you to somewhere that has been set up to take care of patients in this specific need so that you're not infecting patients who are there for various other reasons. And if you're sick enough and they want to run a test and they've got one, that is what they will do. But no, do not immediately just get up and go to the ER unless you really truly feel sick, in which case you need to call 911. But call your healthcare provider. That's the first thing you got to do.
Next set of questions are about spread and likelihood of infection. So first one, can it be spread through the air? And here I think we should talk about spreading through the air as an aerosol versus spread through air because you are standing too close to someone.
So you hear anecdotes and stories of people with, we've got concerns. So when we talk about as something airborne, what we are often talking about is the story with measles. Measles, I can walk into a room, I could cough, I could leave the room, and like 2 hours later, somebody could come into the room and get measles. That's horrific. That's why it's, what is it, R naught of like 14 or whatever it is, because it's so infectious. This disease appears to be attaching itself, or the virus, I should say, is on airborne droplets, meaning I can sneeze it on you and it will be attached to those droplets and go through the air, which is why we have the 6 feet rule, because that's about how far I can cough, maybe. But I can get it to you. I can cough it to you through the air. But it is not, I cough and then it's just hovering in the air. No, that's not, we don't believe that's what it's doing. It's that I can cough and whatever it will go through the air and then land on the table. And it can live on surfaces for a period of time. We don't know exactly how long, but we're talking usually hours to maybe a day, I think is like the high end. Of course, wash surfaces you're concerned about, have common sense. But it is not, we do not believe that it is airborne in the sense that it's hovering and flying through the air and can go great distances. If it were, we would expect it to be far more infectious than it is, and it's pretty infectious already.
So you answered the next question on how long it stays on objects, but they also want to know, does it change for different surfaces? So is it going to stay longer on stainless steel versus plastic?
We're not doing studies, so I cannot definitively answer. I would say that probably the difference is not between, say, stainless steel and plastic. It's probably between soft and hard. In other words, if it gets absorbed versus it's there. Just to be on the safe side, wash stuff. Clean it off. Certainly clean your phone. Clean stuff you're touching all the time. And again, all of this is prevented by hand washing. There could be virus on here and I can go boom, boom, boom. But if I wash my hands, I'm going to be okay. Wash your hands. Wash your hands. Wash your hands. I'm going to, now that I even thought about that. Go ahead.
Okay. At this point, do we know how likely asymptomatic transmission is?
It seems likely. I mean, I think the studies, again, that referencing that pediatric study I talked about earlier, most of the kids, the vast majority, and actually, let's say majority of the kids who were infected were asymptomatic or very mild illness. So it is, yes, very possible that there are asymptomatic people transmitting this, or people who are so mildly affected that they're, for all intents and purposes, asymptomatically transmitting this. And of course, if kids don't know to report incredibly mild symptoms, they are by definition, asymptomatically transferring this. So the short answer is yes, but we don't know how much.
Do we know how long someone sheds virus / at what point are they no longer infectious?
No. Well, we know in the sense by an individual, we can keep testing them until they are no longer doing it, but we don't have a set time yet. And so the only way really to know is to keep testing until you're done. Sometimes they will presumptively just give you an incredibly long period of time and just be like, yeah, 2 weeks, no going anywhere, no doing anything after symptoms have resolved. That's just because we're assuming that after 2 weeks, it's pretty much gone in most people after they've recovered.
And I think we have indirectly answered this one, but someone did ask, they know pets can't get it, but could you pick it up by someone petting an animal who was contagious, and then you pet that same animal?
I suppose, but again, wash your hands. Like, it's like, this is all fixed by, if you pet an animal, wash your hands before you touch face or eat anything else, because it just can't magically get absorbed through your hands. If you pet the animal, wash your hands.
What do we know about if infection confers immunity, for how long, or is reinfection pretty likely?
We don't know. We're assuming immunity just because we haven't really seen reinfection yet. I mean, I think people have panicked about it. We may at some point, because some immunocompromised people might not develop the antibodies, just like with some viruses, which we know confer immunity, some people do get reinfected, but they're usually incredibly small numbers. And that is what we're seeing so far. So we believe that eventually we'll build up immunity to this, but you should be careful.
Just a few questions about risk now. So first, I know kids are less affected, but what about kids that have underlying health conditions like asthma or...
Yeah, they're at risk, certainly, absolutely. And younger kids and babies are more at risk too, probably, at least according to the data that we're seeing, still less than the elderly. But anyone who is at risk, immunocompromised, or has a chronic condition is going to be at higher risk. And no one should treat this incredibly lightly. Like, nobody should be running out to get this just because they believe they're safe.
Yes. I'd like to underscore that point. I feel like a lot of people are thinking that because they're not at risk, like I've seen people say, oh, I'm not in the high risk group. Why does it matter? Because
even like in the low risk group, if it's like, let's say it's a 0.01% chance of death. Why? That means, if a 0.01%, I don't want to do them. Now I'm going to do the math in my head. So at a 1% it'd be 100, at 0.1% it'd be 1,000. 0.0 means 1 out of every 10,000 people that gets it is going to die. You don't want to do that. Why would we want to do that?
And also, please care about the people that you could spread it to in
yes,
the high-risk groups.
I mean, that goes without saying, but even if you personally think you're at no risk and want to infect yourself to just get it, and then you're going to sit inside and not give it to anyone else, you're only putting yourself at risk, but why?
Right.
Why?
What is the level of concern for people taking immunosuppressants for autoimmune disorders so that you're not like as immune suppressed as someone who is going through chemo or getting an organ transplant, but you're still taking something that... Yeah.
These are great questions that would be, we would, if we had well-designed studies and more time, we'd have answers to, and we don't. So we have to go off of what we know just by viral infections in general and other similar type illnesses. And I don't think we can grade or rank those. So we're just saying, if you're immunosuppressed or have a chronic condition, we just know you're at higher risk and we've seen it, and we're just lumping them together at one point. So just take it seriously if you fall into any of those categories.
What's the process for getting a vaccine to the market?
The same as it would normally be. They got to do phase 1, phase 2, and phase 3 testing. First, they got to develop something and think that it actually works, and then go through all the steps. We haven't even gotten to step 1. We got to do safety, efficacy, trying it, all those things. We're just getting started, which is why most people are saying it's probably like a year away at least.
All right, these next few questions are just about the virus itself. So what are the odds of it becoming a recurrent issue, like a recurrent disease? Like seasonal, like the flu, I think they mean?
Oh, well, I mean, at this point, that's what it looks like is going to happen. And so if it follows what happens with flu, if it follows what happens with the 1917 flu pandemic, we will see a peak now, and then it will probably drop during the summer, and then in the fall, all hell could break loose. Because it'll come back with a vengeance, and it won't start in like February or January as it did this time. It'll start like in September, and so by the winter, it could be a nightmare. That's what happened with the pandemic in 1917, 1918. It was really bad, and then it looked good in summer, and everybody felt good, and in the fall, it killed like 50 million people. So we have to be super careful. Now, we will eventually get to herd immunity. It could take 2, 3. I think with that pandemic, it took like 3 seasons to get through it. Eventually, we get to sort of some level, theoretically, of herd immunity. But that's a nightmare scenario because, again, if we're accounting on to get herd immunity somewhere between 40 and 70% of the population to get it, and let's say it's just 0.1% mortality, which is way less than most of the estimates. That's a horrifically large number of people. That is not what we'd like to do. So the goal would be to keep it at bay as long as possible and hopefully get to a vaccine. But we don't know. This is all uncharted territory.
Okay, so can we just, a lot of people were asking about HIV and similarities, so can we just address that for everyone? Really quick?
I wouldn't even bring this up in the same breath almost as HIV, which is a completely different kind of virus, which can take a long time even for a test to show positive once you've actually gotten it, and then can still take a long time before it comes, and then is there forever. Coronaviruses are like colds, remember. It's that we're showing symptoms in a couple days, you're sick for a short period of time, and then you get better. Unfortunately, this one's worse than other coronaviruses, but that is the track, and that is how it works. It really bears no resemblance to HIV at all.
Someone else wants to know, what are the chances that we would see multiple strains of this virus?
We don't know. Viruses can mutate, and it's possible this could. I don't think we're seeing major mutations yet that have everyone concerned, but we don't know.
And why is the fatality rate higher for this virus than some other coronaviruses?
Well, that's what's freaking us all out. We haven't had a virus with this level of infectivity and this level of serious disease since like the 1917-18 flu pandemic, where we have no treatment, no vaccine, no nothing. We've seen other pandemics, but we've had vaccines which we could potentially use, or they have not been as infectious. And we've seen more serious coronaviruses like SARS and MERS, but they were not as infectious. And so they just weren't, we were able to contain them. This is different. This is why I think a lot of experts are freaked out, because we haven't had sort of this level of seriousness and infectivity and lack of any therapy or vaccine since almost basically 100 years ago.
Someone wants to know why the fatality rate seems to be higher in Italy.
So I can give you guesses, but we don't really know for sure. One, Italy has a older population, so more old people, more smokers. It's possible that they are clustered or living in a different way. But certainly older people are going to be the ones that are most affected. And if you have a higher percentage of your population is old, then certainly that's how it's going to show up. But, if you look at the course of number of cases, and I know I tweeted this, Kevin Drum's done a great job of tracking this every day with a chart. We're following sort of the rate of infectivity almost exactly that Italy was, which is why we're all concerned, because that's how many cases and how quickly it's spreading. That is concerning. We just don't know how it's going to play out, which country will most resemble.
So that actually goes right into the next question. Someone wanted to know, as it stands, are we more likely to be Italy or South Korea? It sounds like we're more likely to be Italy at this point.
I think we're more likely to be Italy because we're reacting more like Italy did. South Korea, again, testing like crazy, much more locked down, doing drive-through testing, taking, suppression measures. We're doing much more mitigation measures. That is more like what Italy was doing. Our healthcare system more closely resembles Italy. Our reaction to this more closely resembles Italy, and not necessarily, what they did in China and South Korea and Singapore and some other Asian countries. And so it's probably a fair guess that we will more closely resemble what's going on there. But we don't want to, and that's why hopefully we're taking action a little bit faster. But I would wish we were taking action even faster than we are.
Yeah, someone actually did ask, and I don't know that we can answer this, but they said, why aren't we mobilizing more resources to handle this?
I don't know. I'd like them to, but I'd also like people to take this more seriously. I saw, a tweet from, I love Walt Disney World, but I saw a tweet from Disney World on like the 15th, the night before they closed, and there could not have been more people packed in front of, Cinderella's castle to watch the fireworks. What a nightmare. They're all going to get on planes and go home across to all 50 states, and in Florida still, people are packing the beaches. It's St. Patrick's Day today. I bet tons of people are going to be packing bars. So all of us could be doing a better job.
Okay, and then someone asked a question about H1N1. They said they don't remember there being this much mobilization for that, and so they're wondering if that is true, and if so, why the difference?
So some of it is the timing of the flu and when the pandemic truly came. We did take it seriously. We saw an uptick in deaths. I think we reacted differently, partially because that was also killing the young. And that is panic-inducing in ways that often it is not when we're seeing deaths in a population that we normally expect deaths. But we also we know how to make flu vaccines. And so, even if like the spring was bad, when it came back in the fall, we were better prepared. And so we were in a better situation, I think, to get a handle on it than unfortunately we are for coronavirus, and that is, it's different. We can handle flus a little bit better than we can something that's completely different, for which we have no therapy and really no vaccine.
Okay, we're down to the last couple questions here. So someone wants to know, is it responsible to make claims that X number of people could die when we know that testing is inadequate and we have no idea what the real infection numbers are in the U.S. without knowing about people with mild symptoms who never seek treatment? Aren't we just making wildly inaccurate claims?
Well, the alternative is to make no claims.
Right.
We can continue to update our data and our priors based upon what we're seeing, but we can only model off what we're seeing in countries like ours. So we can say, well, we resemble Italy in this way, and this is what China had, and this is what's we can make guesses. It's not that we have no data, we don't have good data. And so we have to go off the data we can. The alternative is to put our heads in the sand and pretend there's no data. So I don't know what else we could be doing. If we're taking what we see and saying with absolute authority, we know what's up, that'd be a mistake. But again, originally we thought it was, there might be a mortality rate of 3.4. Maybe it's 1. If it's 0.1, this could be a catastrophe. So it's there's overreacting, and then there's like pretending there's no problem at all. We can't do the latter. This is a problem.
Do you have any tips or resources for people caregiving for the sick at home?
Certainly stay in close contact with healthcare providers, but again, supportive care is the best. The body's going to fight this off as best it can. If people get truly sick, they need to go to hospitals. They need to get care. But otherwise, you would care for this as you would if anyone had, any virus. Treat the fever, treat symptoms, keep them hydrated, eat while you can, rest, and love. What else are you going to do?
Yeah, and lots of hand washing, surface cleaning.
Of course.
Of course.
Goes without saying. That should just be it should be playing on a loop behind me somehow. But yes.
Okay, last question. Can you just talk for a second about how important investment in public health infrastructure is in the long term, not only, just for life, but also then to deal with things like this in the future?
The reason we're comparing ourselves more to Europe and not to Asia in this is because Asia has been through this before with respect to things like SARS. So when SARS happened, it was a nightmare, and they learned. So a lot of the facilities being used in China right now and in other Asian countries were built during the SARS epidemic because they realized this is what we need to do in order to care for these viruses. And so we need to be careful because our response is likely not going to be as good as theirs because they invested and they have the stuff that they need to get this done. They know what they're doing. We do not. We skated by in the last few pandemics. MERS didn't really affect us, SARS didn't really affect us, and H1N1 did, but it was a flu. And so we just haven't built the infrastructure and got it going to be ready for these kinds of things. We need to do that. So we've done whole episodes on public health and how we're underinvesting in the infrastructure. But this is the cautionary tale. We need to learn, as other countries did from past pandemics, what to do in these kinds of situations and how to do it better next time. Look, I know I'm never trying to tell people to panic. That's not the goal. Panic will serve no good. But I hope you see in here concern. And I think I've built up enough credibility over the last, 6-7 years of making healthcare triage that I spend a lot of these episodes telling you that the danger is not as big as you think. This is not that time. The danger is real. And I'm very concerned, if you've been following me on Twitter, or if you read my articles, or even watched some of these videos, this is real. And even if the estimates are not as bad as the worst case, and I don't think they're going to be as bad as the worst case scenario, there's significant danger, not only in overwhelming the healthcare system, but to people in general. We need to act. We need to follow the rules of social distancing and physical distancing, and we need to do what experts say we need to do. We need to get through the next few months. In the summer, things may look a bit better, but then we really got to prepare for the fall when this could come raging back. So, take care of each other. Stay away from each other, but still stay in contact because that's super important. But physically, we need to prevent the spread of this virus. Please, please, please follow the rules wherever you are, and let's do the best we can all together. We hope you got something out of this. We encourage you to share it so that other people do as well. We're going to link right here to other videos we've made answering questions about coronavirus or talking to you about coronavirus so that you can be informed as to what's going on. It's very unlikely we will generate any ad revenue from any of these videos, which is perfectly fine. But if you're inclined, you can go to patreon.com/healthcaretriage where you can help support the show and help us to be able to make good videos like this, which hopefully do some good.